explain the Canadian healthcare system. And he would say, hey, Tony's got a great idea, let's do that thing. And I soon realized that, many of the people that were working with Kennedy in those days had actually designed the Canadian healthcare system. So it wasn't like they didn't understand it. It was the inability to take that solid policy with proven track record and implement it in the United States. And that was the difference between policy and politics. The second galvanizing experience for me was actually when I met Sandra, which was in the early 1990s in San Francisco after I had finished law school. After medical school, I went to law school. And I came out roughly around the time Bill Clinton was elected, and here was a Democratic president with a Democratic House and a Democratic Senate, and the single most important domestic priority was healthcare reform. So I was like, okay, I'm in, and I got a job with Consumer Reports, which I had an office in San Francisco, and began as a policy analyst and a staff attorney working on local, statewide, and federal health reform. So I met Sandra in the context of San Francisco's Medi-Cal managed care reform efforts, and was just struck by the potential for reform in California. And of course, we all know that all crashed and burned. Despite having all of the politics aligned, there was still the ability of the opponents, the maintainers of the status quo, to thwart that entire effort. So that was a big lesson to me too. Basically, in power, and policy is not enough. You have to understand actually how change happens. And being I was a registered lobbyist and a staff attorney, I learned the mechanics of policymaking. And those have served me well to this day. So I ended up at the California Endowment, and that's a sort of a long kind of coincidental story that I won't get into, but the bottom line is that I was asked to come in and help craft the basic architecture for a 10-year-long, roughly $1 billion initiative to try to make measurable change in the health status of about 1 million Californians across 14 communities. And it was basically a blank sheet of paper. And I and several others was asked to design an initiative to actually move through the social determinants of health, health improvement. And the only caveat was that we couldn't spend a nickel on healthcare. And so that's what I do now. I've had 10 years of experience there, which have been just more fun than I could even describe. And we felt like we've contributed to some very significant policy change in California. And I think that, as Sandra said, this principle of enlisting the participation of the people that are most impacted by the inequity in the shaping of the solution is a principle that we live by at the California Endowment, and it has proven itself to be an enduring and effective principle.
Great, thank you. That was really, you talk about power, and I think that concept, or that what you said about the ability to drive policy, and you have to manage with understanding the power landscape, and I think that is and I think really resonated with me, and I really appreciate it. We did get a shout out, by the way, Tony, from Manisha Sharma, who's still in Baltimore, so she wanted in the chat. So just wanted to mention that. So no,
Sarita,
this is really,
I can't help but add here that CHCF for 18 years has been supporting the fellowship program. And a principal hypothesis there is you are not going to change a delivery system if you don't create power within it and leadership within it. So a very core tenet of CHCF's hypothesis about the delivery system, which I know we'll talk more about, is this program. And so I couldn't resist in the conversation themes that Tony and I are riffing off of making that point.
Yeah, thank you. And of course, so thank you, this California Healthcare Foundation for the support of this program. And I think as we talk today, certainly we will want to understand how we can continue to, again, affect change. What can we do as alumni to really to push these agendas forward as we talk through them. So Thank you about that. You know, I think one of the things we also, you know, as I mentioned, and I went through kind of the day 1 and day 2 of the program, of the alumni meeting, you know, we had several themes that emerged. You know, themes around childhood trauma, systemic racism, the pandemic response, COVID-19. How do we, you know, really shape and influence policy in response? Partnerships, integrating multiple voices, perspectives of stakeholders, breaking down silos. I mean, the list goes on and on. We're looking for the hope of the future. So one of the questions, since both of you work lead foundations, you know, what can and has, I think, already been done, philanthropic organizations like the California Healthcare Foundation and the California Endowment do related to some of the themes I just mentioned, and, you know, again, more kind of the future, what is underway and a prime focus for your organization. So, you know, maybe I'll start with Tony this time, if you wouldn't mind reflecting on and providing us some insight into that.
Yeah, it sounds like you guys had a great day of conversations. I mean, I wish I had been there. You know, on this issue of trauma, you know, it's clearly something that has resonated with me throughout my career. You know, what I described in East Baltimore, I didn't have the words for in those days. I mean, it just looked like people had lost hope. I used to describe it as sort of a sense of futurelessness. When you interacted with people in a shop or on the street or patients, you saw this faraway look in people's eyes. It was like they couldn't quite engage you. And I found myself for the first few years in Baltimore always trying to catch somebody's gaze. I couldn't understand why they wouldn't look me in the eye. And, you know, I spent some time during medical school in South Africa, you know, trying to study apartheid and its impacts on the health of Black South Africans. And I lived in Soweto. And one of the things that I noticed in Soweto was that people looked you in the eye. You know, and there was this sort of deep sort of level of connection and engagement. And it felt like, you know, they felt like apartheid was sort of on the run and that they had kind of the upper hand and that they were going to see change in their lifetime. And it gave them a sense of agency, you know, the sense of control over what was happening in their lives. And I realized many years later that that's what was missing in the eyes of so many people I saw in East Baltimore. It was this complete sense of a lack of control. Like they were just being buffeted about by, you know, forces outside of them, and they had no real agency. And so, you know, getting to this issue of trauma, I think that trauma actually erodes hope over time. People who've been traumatized basically lose a sense of the future and a sense of their security in the future, and they have a constant kind of reminder that they're vulnerable. And so in our work, you know, I said that, you know, the task was to figure out how to spend $1 billion over 10 years and over, you know, for looking at about 1 million people. We ended up spending about $1.8 billion over those 10 years. And we learned 3 things. I mean, you know, it sounds kind of silly. You spend $1.8 billion and you learn 3 things. Well, those 3 things ended up being very important. And I call them the ABCs. And it ties directly to this theme of trauma and sort of structural racism. So, and for agency. And agency is, again, what I'm describing, I saw in South Africa and Soweto during much worse material deprivation. I saw in people this sense of control, this sense of hope, this sense of a future that I didn't see in East Baltimore, where people were living, you know, they weren't obviously wealthy, but they were living in material conditions that were much better than Soweto. And so we've discovered, I think, probably not really a discovery. I mean, people have been saying it for a long time, but I think we realized that health is really about control, and not so much at the individual level, although that matters, but also at the family level and at the community level. And that our goal is to essentially build this sense of agency at the community level so people can more effectively participate in holding institutions accountable for equity. And our primary modality for building agency is organizing people, building their political, social, economic power. So that's the A of ABC. The B, and this to me, I think was the biggest and most exciting discovery of the work of building healthy communities. The B stands for belonging. And belonging I like to describe almost as the opposite of racism. It's a sense of being heard, being seen, having your voice count, and being appreciated in your full humanity. And so much of racism is about dehumanizing people. It's about devaluing them. It's about making them feel like they don't matter, that they're not seen, that their voice doesn't count. And that's what I saw in East Baltimore, the cumulative and synergistic effects of structural racism, interpersonal racism, institutional racism, manifesting itself in the lives, particularly of young children. And you would see that light in their eyes that I described start to extinguish as they became, 13, 14, 15 years old. And it all of a sudden, it made sense to me. It was that sense, that lack of a sense of belonging. That what racism does is it erodes your sense of belonging. And in doing so, it dehumanizes you. It makes you feel like you're not fully human. So those were the A's. That's the A and the B. And then the C is, something that we all understand. I call it changing the odds. It's really about the social determinants of health. It's about focusing on the root causes, not just on the symptoms. And so we have so much of our response is a programmatic response. It's like more services for these people, a new program for this particular concern. And rarely do we ask ourselves, why do we need all of these programs? What's the fundamental driver of these, these adverse outcomes? And so, every spring we go through a kind of a moment in the sort of collective American experience where we start to see kids getting into college. And there's always one story about that one kid who got into all of the Ivy League schools. And that kid, had a mom who was a maid and a dad who was a janitor, and they were immigrants, or they were super poor, or was a single mom, and this kid beat the odds. And that's like a front page story about this, incredible kid. And it always pisses me off. Not because this kid isn't deserving of credit, it's the story has got it all wrong. Of course, there are smart and talented and extremely gifted children all across this country, across the economic spectrum. The story is, why are so few of them able to achieve these kinds of goals? That's the story. And that's the difference between beating the odds, which this kid has done and deserves credit for, and changing the odds to allow all of these kids with these talents and skills to essentially develop them and contribute to the society that we all benefit from. So that's what we learned. That's what ABC is: agency, belonging, and changing the odds. And that, it cost us $1.8 billion to figure that out. But now we're actually, applying that in every aspect of our work.
Great. Well, I think a lot of us on this call are probably on this Zoom are probably taking that down if we weren't familiar with the ABC, because I think it should kind of, I feel it should be kind of rooted in this work as we're really trying to, to work with communities and work with populations that are particularly vulnerable. And I think you really helped us shine some light on how we need to be thinking about things. So really appreciate that. And, one question follow up before I turn it over to Sandra to talk about the work of the foundation, California Healthcare Foundation, is, how are you starting to measure some of these things? Are there, I've seen some of the work that, obviously the work that the endowment has done, but think, how do you really measure, for example, that belonging that you talked about? Are we, and how is the endowment framing that, to really understand if we are affecting change?
Yeah, so I'll try to give you the short version of this answer, but I can go into some depth on this if anybody's curious. And I see my friend Minnie Swift on the screen. Hi, Minnie. And I see Ann Lindsay. Hey, Ann. So there are other people here. Good to see you. So we have a theory of change, which is pretty basic. Our mission, and that's filed with the state, it's embedded within our articles of incorporation, are in part to, and it's the same as the California Healthcare Foundation, mind you. So we kind of ride this thing where we kind of split the landscape. up, and we focus on the health status improvement part of our mission. And that health status improvement, we think, is largely driven by the policy environment. The policy environment actually facilitates health status improvements, because you take a kid in East Baltimore and you look at the environment in which the kid is living, both the social, the physical, the economic, the services environment, it's all deficient. Virtually every system is on life support in so many of these communities. And so we feel like we can create environments that are more likely to allow for young children and families to have high life trajectories. So if you believe that your goal is to change health status, and that health status is shaped by the policy environment, then you have to figure out, well, how do you actually change policy? And our conclusion is not rocket science, that every major public health change that has happened in this country, every single one has been driven by organizing and power. There's none that have been driven just by science alone. You have to actually have folks working to advocate, to drive, to make that policy change. If science alone was enough, we'd have universal health care, because we have like over 100 studies that show universal health care is associated with better health outcomes. We'd have universal child care, because we have all kinds of studies that show that universal child care is, high quality child care is essential for high life trajectories. So science alone is not enough. You've got to actually have power. And if you've got to have the power to change the policy, you got to organize people. So we take our theory of change and we just measure all of those elements to see, are we building power? Are we changing policy? Are we changing environments? And then ... we expect to see with those things change over time, health status change. Now, the longer version of this answer, gets into things like, belonging is largely driven by changing the narrative. The best example of that is undocumented Californians, who in 1994 were, the target of Prop 187, and a governor who said that, I take pride in the fact that I'm excluding undocumented Californians from education and health services. And Prop 187, I was there. It was the time when I first got to know Sandra. We were working on Prop 186. It passed with almost 60% of California's vote in 1994. And then you fast forward to today, and the narrative has changed dramatically, not passively, through the actions and intent of thoughtful advocates who've reshaped the narrative about what undocumented Californians bring to the rest of us, and how we share humanity with our undocumented brothers and sisters and neighbors. And now we've seen, undocumented children getting access to healthcare. We've seen driver's licenses. We've seen in-state tuition, access to scholarships, access to medical licenses, et cetera, et cetera. Those were unthinkable policy changes in 1994. And that's not just a passive demographic phenomenon. That's a product of people changing the narrative about and building the humanity, and mostly undocumented people themselves, building the humanity of undocumented people, creating a sense of belonging amongst all of Californians and undocumented people, that we are all Californians and our fates are inextricably intertwined.
Great, thank you so much. And by the way, somebody, I think it was Minnie, who asked if you were you the writer of the ABCs? Can we coin it? Can we quote you moving forward as we apply the ABCs to our own frameworks? Do we quote you directly?
I'm not good at very many things, but one thing that I am good at is creating simple frameworks. So yes, I did create the
Thank you. So Sandra, yes, I mean, I think, a lot of what, we heard from Tony, I'm sure, you can reflect on, but also obviously with your, with the California Healthcare Foundation, we'd love to hear a little bit about what kind of work, you've been doing and some of these themes that I spoke to earlier.
Sure. Let me first pick up on this theme of accountability, because I think it's such an important point. I'll share the story that when I was director of health in San Francisco, every other week you have the public, and you have public testimony, and you have an agenda, and you're working with a commission, and you've got all these materials prepared. And most importantly of all, you have a set number of high priority things you're trying to get done, right? You're the director of health, you run massive departments, but you got to focus on Medi-Cal managed care and moving, the paramedics from the fire department and, big picture things. But every other week, you're being accountable to the public. And suddenly you are the system. And I say that in part because everybody that's on this screen is part of a system that has all kinds of rules and de facto power, right? All clinicians have agency and power and influence, and we all sit in these institutions. Anyway, long and short of this little anecdote is every other week, we'd have these public meetings, and this gentleman would come, and he had lost his hearing due to lead toxicity. And it turns out he was being funded by a philanthropic agency to lobby the Department of Public Health to do something much more systematic with regard to screening for lead toxicity. To be honest, lead toxicity was not high on my 10 priorities that I was trying to get done as directors of health. And so every meeting I would write, lead screening, follow up, next meeting, lead screening, follow up. Finally, one day I was like, okay, I got to figure out what this is. So I get the environmental health folks and the MCH folks, and I get them in the room and I say, what are we doing on lead screening for kids? And everybody looked down. I was like, oh, this is not a good sign. And so my point there about accountability is even when you have enormous power, right, your accountability in the system in which you are really does require philanthropic supportive advocates to go and just bang on the director of health at every public meeting to pay attention to something that actually we were doing a perfectly terrible job at. So anyways, accountability to me is just a huge piece of how we think about systemic racism, right? Because there are so many normative behaviors that happen every day in our delivery system that we are very accustomed to, that very much perpetuate the kinds of health outcomes that we see out of our delivery system. I mean, think about just the notion that we have COVID-19 breakout. We spend 18% of our GDP on healthcare, and we don't have enough PPE to protect our frontline workers. I mean, really, that is extraordinary. And so the California Healthcare Foundation does come out of the same cloth as TCE. And the notion there is so much unnecessary care. There is so much frictional costs in our delivery system. These are dollars that are not in public education. They're not in public spaces. They're not helping us with getting clean water into, the central part of California. And so, and by the way, ridiculously hard to change the delivery system. I just have to stipulate, right? I don't know whether there was some decision made by Mark and others when these two organizations were formed. But CHCF has always stayed in the delivery system with a very specific focus to really understand what the levers are for change, of which leadership is clearly one, media and communications is clearly two. And then really just sort of thinking about the practices of our delivery system that we want to change. I remember as a medical student, I went to the head of infectious disease and said I wanted to go to Mexico and study infectious diseases in Mexico. I was in school in Boston. And he said, why in the world would you want to go to Mexico and study infectious diseases when everybody who's in medical school in Mexico would like to come to Boston? I said, great, we should do an exchange. So long and short of it, I ended up doing 6 weeks in Mexico City in infectious diseases. And when I came back to Boston, I was in absolute culture shock. I was in a 4th-year student at that time. I was doing a medicine rotation in a hospital outside of Boston proper. And the cultural norms, which I had been, we were all raised in these programs, right? Were so distinct culturally from how families and clinicians and delivery system in Mexico, which is much less resourced than ours, operated. And your fourth year medical students, of course, you've got your intern, you've got your resident, and I admitted a very sick woman from the nursing home with the urosepsis, and I couldn't get anybody to round on her. It was like an invisible patient, an African-American woman. She had no family, she had no advocates, and nobody would round on her. And I as a fourth year student, part of it, I had just come back from Mexico, but part of it, you just know, like, so I finally went all the way up the chain of command. I went to the chief resident and I said, something's wrong with this because I'm only a fourth year student. And what are we doing here? And there are so many elements within our delivery system where that's at play. And so when CHCF, when there's an opportunity to go there and really think about delivery system change post ACA, I thought that was an incredible opportunity to get back into thinking about how the delivery system might look differently. Tony talked about when we did Medi-Cal managed care. Remember when we did that, that was a defensive move. It wasn't with the notion that we were going to have 13 million people in a Medi-Cal program, which we do today. So CHCF is focused very much on making sure that we provide the best, most affordable, most timely care with the notion that patients have agency, right? That their experiences as well as their outcomes in the delivery system matter. So whether it's working in birth equity, which we are doing now, everybody knows we've reduced maternal mortality quite significantly in the state. And yet if you're a Black woman today giving birth, you're 3 or 4 times more likely to die during childbirth or subsequently. And by the way, that data point has not changed since any of us went to medical school, and probably in many years before that was yet worse. How do you do that? Well, same principle here, right? Bring together, first of all, we have employees at CHCF who are African-American women who have given birth in hospitals in the state. And really trying to understand what their lived experience is something we've been trying to figure out how to tap into, even as we do all the other things we do, which is try to develop a patient-reported outcome for maternity. Create an advisory board, national and local, of folks who are working in this space and help us build a portfolio. One which we will be in for, easily a decade before I suspect we'll make any significant progress there. But important to sort of take the systems view of the delivery system, really understand from a data point of view, and Tony's absolutely right, data alone will get you not very far. You can write a nice paper, and you can write a nice infographic, and you can write a nice issue brief, and by the way, we do that all pretty well. But actually changing the systems, there are only certain levers that you can play to do that. And right at this moment in time, I would argue, in large part because of the murder of George Floyd, and really a generation of people who have now agency and now want accountability from all of our systems, there is a very disruptive moment in our delivery system to begin to get at things like these disproportionate rates of maternal mortality, or the absolutely horrible way that we deal with maternal mental health, right? CHCF is doing work both within the organization, as every organization ought to and is. And really the opportunity that we have with this disruption are tremendous, right? I mean, we have been working as a foundation for, I don't know, over a decade on trying to expand telehealth. And as Kelly mentioned in the policy session earlier today, literally over a weekend, suddenly everybody's trying to figure out how to do telehealth. Now it's been happening at Kaiser for, quite some time. But all change in systems have stakeholders who benefit from the dysfunction of the system itself. And it is hugely important, I think Senator Pan referred to this in his remarks, hugely important to understand who those stakeholders are and to engage them. Not just with data, but really to understand what are the motivations. And there's seriously mentally ill. When I first came to CHCF, the board asked me, what would you want to work on? And I said, we have completely disaggregated mental health from physical health in virtually everything that we do. And by the way, our system further stigmatizes mental illness, right? And so one of the big priorities that we've had for some time is to really, and keep in mind, I ran a county health department. I am a great believer in public service. And I know how hard it is. I know how invigorating it is. I know what the tools are to be used there. When we carved out mental health from physical health, we created a systemic barrier for people to actually be treated as whole people. And it's a system that has great stakeholders embedded in it, as Kelly well knows. And, a lot of work in this space that we will continue to do. But my main point here is you have to, and curiosity, Tony mentioned this. I think everybody on this phone has an innate sense of curiosity. And part of your clinical training is this notion that you're continuing to learn. But, systems thinking is break down the systems, try to understand how you get here, and try to ready yourself for the moment that you have an opportunity to actually make a significant change in the system, as we're seeing now in telehealth because of this pandemic. And you could work for years and years and years on a system change with good data and with convening and bringing the stakeholders at the table. And then as Senator Pan says, it goes through its politics and body politics, and you may win some and you may lose some. But fundamentally thinking about healthcare delivery as a system that largely does not put power in the hands of the patient is the most fundamental problem we have in healthcare today. Because if you look at things that Native American communities have done in Alaska, where they sort of said, we're advisors, this is your delivery system, what do you want to prioritize? Well, we don't do that at all in our healthcare system, not at all. And so tools that give consumers and patients more agency is how we're going to ultimately make the kind of system changes within delivery system that CHCF aims to do.
Thank you. Really appreciate that. And I think it really, I think you touched on something that I was, going to ask you, but it is around, like, in the midst of the crises, the pandemics, you've, obviously your core areas around system change are still part and parcel of your efforts, but, like, also having to, elevate some of the work in telehealth and things of that nature seems to be, I know that was one of your priorities in California Healthcare Foundation. So it sounds like that has continued to have momentum. And I don't know if you want to say anything before we turn it over to, I want to make sure that we give opportunity for folks on this in the audience to ask questions of you as well.
One thing that Tony and I didn't mention that we should, right, is, the other thing, of course, that is happening, and I think it's, we have many examples of small successes in this place, but philanthropy in the state of California has stepped up in an enormous way with leadership, voice, convening power, advice, giving, doing polling, listening to low-income folks in surveys to understand what matters to them. And philanthropy working together in a public health arena. I mean, Tony and I both have been and came out of public health. CHCF does not typically work in public health. We also don't typically have a pandemic, right, where we have more than 200,000 Americans that have died of this virus. And so I do think you have to sort of step out and sort of use your leadership, your platform, your resources, your networks, when a moment opens up where there's just tremendous need. So, Tony's been leading an effort on contact tracing with, half a dozen or more foundations, some health, but not all, to try to figure out how we actually build a local workforce of trusted people from their communities to be able to do effective contact tracing. And so, you know, I think you also have to be incredibly resilient and flexible and understand all the tools at hand when you have these kinds of public health emergencies that we're seeing with COVID-19.
Thank you. Thank you so much. Well, I want to make sure I give an opportunity for folks who are in the audience to ask any questions or reflect. We're getting a lot of, I think, important reflections. I don't see per se any questions, but offer the opportunity to folks to unmute themselves, maybe raise, there's the hand raise function. So if folks have questions they want to pose or reflections, please do. Is there anybody to take her here, or we can also read some of the things we've heard through the chat. Any thoughts, comments, questions? Okay, it looks like somebody does. Okay, I think Manisha, Shara, do you want to go ahead and unmute yourself?
Hi there. I just want to thank you so much, Dr. Hernandez and Dr. Eaton. I'm not actually in Baltimore now, but I am an East Coaster planted in California. It's Boston, New York, Baltimore, DC. So I was up and down the 95 corridor. So totally get it. I'm cohort 19. As one of my colleagues said, we're COVID-19, cohort 19. I just have to tell you that I'm so grateful for the space of CHCF. And, you know, it's just an amazing space of leadership, encouragement, safe space to just sort of talk through the future. And I'm just curious, like, as someone who's still going through the cohort, and I'm loving that CHCF is, you know, recognizing health equity, and it's and just really thinking about the internal sort of revamp and then what the future is. How do we, as folks who want to be invested in CHCF and invested in CHCF's future, a lot of it is also sort of taking a reflection as an organization and how that reflects outside, and how can we be a part of that process? Especially when we talk about disruption and organizing, that's actually, you know, as our good Congressman John Lewis would say, it's good trouble. And it's really important to be making good trouble, but a lot of it also is just sort of what that looks like moving forward and how we can invest intentionally as folks who want to be a part of it, but there's a little bit of a archaic system framework. So how do we plug in, basically, is what I'm trying to say.
Well, let me make a couple thoughts on that. You know, Tony referenced Prop 187, that's dating us. But, you know, on a November ballot is Prop 16, right? And Prop 16 would overturn the ban on affirmative action, which has been in place in this state for 25 years. And, you know, Tony talked about, you know, the front page story of a kid who makes it in spite of all odds. You know, something like 59% of seniors in high school in California are Latino, Latinx. I'll get the terminology right here. And entrance into UC is somewhere around 22%, 23%. And so, you know, the anecdote that Tony gave is, yeah, that kid got into every private school and went there, right, and leaves the state. And so, you know, those are places where this network could have an extraordinary impact. I mean, everyone's talking about, you know, the next administration and, you know, flipping the Senate. And I'm sitting here looking at things that are on the ballot today that a network like this could have enormous reach. And where, if you think about workforce in the state of California, and you think the incredible disparities that exist between the population demographic of the state and the people that we have serving them in the delivery system, it's extraordinary. It's just extraordinary. So I could, you know, I'd be happy to sit with the alumni board and give you a list of a half a dozen things where I think this network could weigh in and have enormous benefit. So it does require sort of picking your topics, and CHCF does have and has had interest in workforce for some time, in large part because the CEOs of all the healthcare foundations get together periodically to, just share stories and priorities and learnings, and and one of the things that was clear when I first joined CHCF is that all the healthcare foundations were dabbling in healthcare workforce, but there wasn't actually a plan for how we might address it. And so we came together and put a commission together and put a plan together and put a set of recommendations together. And lo and behold, that's a plan that if this network would get behind, there are numerous things that you could do to actually promote the workforce of the future, for which, by the way, physicians as an organized entity are often opposed to. Right? So the voices of physicians in that space would be incredibly powerful. I mean, Senator Pan referred to this earlier. I think thinking about what you have learned as leaders, the organizations in which you are in, and the networks which you have enormous innate power if you decide to come together and say, we're going to focus on, for example, Prop 16. Which I'm pitching, flagrantly pitching. It's not polling well. So, for everybody talking about systemic racism and the lack of opportunity, where's the physician leadership on Prop 16? Prop 15, you could say the same thing, right? Split tax, right? This would be, this is the low-hanging fruit from Prop 13. I mean, this is a state that acts by putting propositions on the ballot. And so, you can be defensive sometimes and offensive sometimes. But what I would say is that organized CMA may not have the same leadership vision as this alumni group might have on different subjects. And so I think there's just enormous opportunity and power in the network. We, by the way, talk about that at our board every time we reappropriate the grant. And there are many examples of, these chips that had network support and that got scaled. eConsult being one of them, but not all of them, that came out of a chip. So I see a lot of opportunity for scalability of chips, some of which requires some policy work in order to scale. That would be an incredible role for the network as well. A couple examples, Sarita. I hope I answered the question.
Tony, did you want to add anything to that? I think in terms of anything else to dovetail on what Sandra mentioned, in terms of how, I think this was a question we were going to pose to you anyway about what this alumni network can really do to, to really push some of these agenda items forward.
Yeah, I don't have much to add to what Sandra said. I know some of the, although your names are really small on my computer here, I know some of the people on this screen who have been very active in policy advocacy across the state and have been very effective. And, I think that I teach at Berkeley, I teach a class on public health advocacy, and I have for the past 10 years. And one of the things that, we teach in our class is that, the credibility of physicians, nurses, and people who are healthcare professionals is extremely high in the mind of the public. And how you leverage that credibility to both educate the public about the true drivers of health, as well as to support initiatives around the state that will improve health, is really critical. And I think it's part of medicine. I mean, that's what Rudolf Virchow said back 170 years ago. Physicians are essentially the natural attorneys of the poor. And the role of professionals in healthcare goes beyond just delivering services. It also goes to how we construct both our healthcare systems to allow them to lean into community health and actually leverage opportunities to improve the health of communities, as well as how we structure our society and how we use resources, which is something that Sandra was alluding to, with the 18% of the GDP going to healthcare, and how that essentially starves other determinants like education and childcare and a variety of other critical determinants that actually have more influence on the health status of populations than does healthcare.
Great, thank you. Renee, I think we have some other questions. I want to make sure that we address those as well. Let's see here. I don't know if you want to call out. I think it was,
yeah,
I see the Tahoe crew. Yeah.
Sorry, my background is horrible, which I need to change. There's a question that the Tahoe crew has, and there's also a question around advocacy and the ability of alumni to do that.
Do we want to have the Tahoe crew ask their question or directly, or?
Yeah, sure. If they want, if they can unmute and ask their question.
Yeah.
All right, well, we're going to try to unmute and do this. There's a whole crew of us here. Cohort 18 representing Tahoe. Our question, so, yeah, the question of how we advocate, and actually as CHCF alumni, because I know some of us are involved, like there's a policy group, etc. And then our other question was around the idea of why stress and emphasize philanthropy so much when there's the idea that we should just fund public health directly and make it a priority. Thank you.
I would just say, you know, this particular crisis, if this crisis does not have this country take the opportunity to really interface public health with the delivery system, if not now, I have no idea when. This is an example where you know, a public health system that has been systematically eviscerated from a public health point of view. Data point one, when the state went and just assessed our 58 counties for anybody who had any contact tracing expertise, something like 25 of our counties had someone who did contact tracing. To me, again, you know, the 18% GDP, you know, less than 1% of that GDP is in public health, if that. So this is the moment in this pandemic to make the case for how important it is for those pieces to fit together and to do so effectively. And I'll give an example because UCSF did a grand rounds on why the mortality rate in San Francisco for COVID was so much different than Los Angeles, New York, Chicago, Miami, etc. And, you know, there's probably attribution issues here, but it is a combination of the fact that the health department, the private hospitals, and UCSF and the health department are integrally linked through an MOU and have worked together for a very long time. And those hospitals, the health department and UC have worked in the HIV epidemic as one unit. That is very unusual. It is just very unusual. Most of those systems are much more fragmented than they are in San Francisco. And so if you look at it in concrete terms, mortality rates significantly less in spite of the fact of a big Latinx outbreak of COVID in the mission due to dense housing and essential workers and the like. And yet, if you look at mortality rates, the synchronization, the coordination, the collaboration, and the trust, and the experience in working together previously, I would argue, have all significantly led to a lower mortality rate due to COVID. And so it is a case study in that regard. And we'll look at attribution and look at the data that actually leads to that. It's probably a few other things, including a good head start, elected officials that are bold and willing to do things that are unpopular, and a population that takes public health advice and acts on it. I think masking in San Francisco is north of 85% of the population if you look at local polls. So this is the moment in time in this country to recognize the underinvestment in public health and to understand the data piece. If you look at countries who have managed COVID extremely well, they all have one data system, public health, they know where you travel, they have the same public health system, the delivery system, the HR, it's all one system. Everything that we try to do in delivery system reform is stymied by this data set and that data set, and how do we integrate it, and what do we do about it, and is the data accurate, and what's the lag, and do we need a health IE, and oh my God. And so I think this pandemic is the case study for the integration of public health and the delivery system. And we in the delivery system should be advocating profoundly for that to happen. Not just as a one-time bailout, but to recognize the role. I mean, you know, we've had 6 public health officers, I don't know, Kelly might have the number better, 7 health officers who have been pushed out, nudged out, quit during just the last 6 months of this pandemic. And yet, if you think about those roles, they're extraordinarily important roles fundamentally to controlling this pandemic and all the ones to come. And this won't be the last one. So I think this is the moment in time to integrate that, to integrate our data systems, and for the delivery system to be advocating for that interface. I say that, you know, as a unrecovered former health officer.
I would just add to that, I agree with everything that Sandra just said. I would, in 2009, I left governmental public health and went to the California Dom. And at the time I left, I was running Alameda County Public Health Department. We were working on H1N1 influenza. We had pandemic preparedness plans. We had a statewide stockpile of essentially, you know, ventilators and N95s and countermeasures. And, you know, that was the result of roughly 10 years of investment in public health infrastructure that arose after, you know, September 11th. It was actually October 11th when we had the anthrax scare in Connecticut and New York. And that stimulated just a series of investments in anthrax, bioterrorism, and then subsequently pandemic preparedness. And we even had, you know, exercises for smallpox and monkeypox and a variety of other things. And public health got a huge investment. In fact, I used some of that investment to do community health improvement in Alameda County in the mid-2000s. So when I called my former colleagues in the Bay Area to see what, you know, we could do to help them respond to COVID, and I would ask questions like, you know, so when do you actually start releasing the stockpiles from the statewide, you know, strategic stockpile? And they'd say, what stockpile? And, you know, I'd ask them these questions about, okay, well, do you have a sort of refreshed pandemic preparedness plan? And they're like, pandemic preparedness, what's that? And I was stunned that all of that support and infrastructure building had just eroded over 10 years. It was gone. And similarly at the federal level. And so, you know, it's amazing to me how we run through these boom and bust cycles in public health and pretty much everything else we do in the United States. And we have these short-term memories. I do believe that COVID will stimulate another decade or so of investment in public health infrastructure. I mean, I'm an optimist, so you know, and the experience of seeing what happened with anthrax tells me that there will be a sustained investment, although it will probably be a narrow investment around pandemic preparedness. And the key for us is to do what Sandra's talking about, is to leverage that investment to actually merge that interface of public health and the clinical care delivery system and mine that interface. That's where the future is. Right now, we're still living in two worlds. We've been living in two worlds since I started in this business. And we have an opportunity to actually start to merge these worlds now using the justification of COVID-19. The second thing that we can do in this moment is really continue to raise the profile of health inequity and the structural drivers that produce 61% of all COVID-19 cases in this epidemic have been amongst Latinos. And so that means that the latter half of this pandemic, it's probably been closer to 75 or 80% of all the cases have been amongst Latinos. And disproportionate amongst those Latinos are non-English speaking Latinos who are not even speaking Spanish. Many of them are speaking indigenous languages. These are layers of vulnerability that are producing profound risk of folks that cannot remove themselves from harm's way. And we depend on them for the essential services that they provide, including feeding us. So that is as glaring an inequity as we have ever seen. And if we can turn our eyes away from that and pretend that it's not happening and not rush in to correct that structural inequity, then there's something deeply wrong with us, deeply wrong with us. So our big test is going to be vaccine strategy. Can we get low-income, non-English speaking Latino essential workers to the front of the line to get COVID-19 vaccine because they are at the highest risk? That'll be a test. If we can't do that, and our experience with influenza suggests that we cannot, then it's shame on us. And I'm a hopeful person. I think we're going to make these improvements. I think that this has been enough of a shock to our system that people feel universally vulnerable and understand that as I said before, our fates are inextricably intertwined. But I've been proven wrong before, and I probably will be proven wrong again.
Thank you. Renee, I think we have a lot of questions. We have about 15 minutes. I think we should continue with the questions because both Tony and Sandra have done a fantastic job covering a lot of what I think I was even going to pose in terms of questions. So do we want to go to the next one? I want to make sure I track who's next on the list.
Yeah, we have Amy Shin who has her hand raised, and then after that will be Mimi Duhan.
Great. So Amy, you want to unmute yourself?
Amy Shin, cohort 4. I think one of the older cohorts here. And it's sort of a follow-up question to the last one that both Tony and Sandra just responded to. I think if not now, when, right? We're going through this still, and the divestment from public health for decades is just glaring at us. But we're also, because of COVID, it's facing a budget deficit, a large budget deficit. So outside of Prop 15, what others, we know, and I think everyone buys into that this is a time to invest, and we know how to do it having gone through this. But what about the financials? And also, while I was at the health plan of San Joaquin, I had the pleasure or not of being the chair of the board of the local HIE, and the lack of community coming together despite the health plan funding most of it was just so troubling. And all of that takes so much money, right? And so I just want to see if you guys have either one of you or both of you add to your comments that you just made, and add some financial flavor to that discussion.
Always nice to hear from you, Amy. and I really appreciate the question. And actually, the example of a Health IE is a really good one, because I think likewise this is a moment where lack of data, lack of connectivity of data, lack of agreement of how to use data has very much hindered so much of our response to COVID-19. And I'm not, I'm an optimist as well. I mean, I don't think you do this work if you're not an optimist. But in the policy conversation earlier, I was struck by the conversation that Senator Pan was having with Kelly and with Alice. And what I would say there is, yes, so much of what we do in public health is done in counties. However, there is something to be said, just as this country would have done much better with a national strategy to address COVID-19. So too, I would argue that the state saying this is how we are going to collect data. These are the data elements we are all going to use. How we get there is another question. but setting the standards and the rules for health information exchange and how and what we're going to put in there and how they're going to be created, to me, would be so much better than doing a health IE in San Diego and doing one in San Joaquin, and then having, you know, whole person care ones that are working off of Excel sheets. And every program that we have builds some new crazy data system. And so I would make the argument that this would be a good time for the state to say, this is as a state how we are going to think about the collection and sharing of data. We have spent so much time talking about HIPAA as if there is anything known as privacy anymore, by the way, on social media or anyplace else, and hid behind it to really think about how we use data in population management, in public health outbreaks, you know, registries and the like. So I say that noting, by the way, that CHCF has a big effort in this. And in our board meeting yesterday, we went to the board and said, we again think we ought to lean into health IE. And again, I don't think this is a, you know, local or even regional issue. I do think this is one where state leadership would be incredibly important if we're going to get out of a very piecemealed approach to health IE and data collection. So I didn't answer your finance question. You know, I have a lot of faith in our Speaker of the House, in Nancy Pelosi, and I think she's well aware of what's needed in public health and public health financing, and to a certain extent in helping states that have been disproportionately impacted by COVID-19. What the politics are of that between now and November 3rd, somebody better than me could answer. But if you are an optimist as I am, I'm optimistic about an administrative change in DC. And I think if that happens, it's very likely there would be a relook at actually how we are integrating and paying for and creating a long-term sustained public health program. If you look at life expectancy, it has not been by what these, you know, multi-billion-dollar buildings all over the state of California have built. That really has not given us the kind of life expectancy that investments in public health have done. And the data is really clear on that. And I think time that we think about our philanthropists who huge buildings, and really make the case to them that putting your name and stakes behind and your political muscle behind really building a public health infrastructure that focuses on population health for the long term is the right financial investment for our country and for our state. And yes, we had to get behind Prop 15 as well. My other plug.
Yeah, I will just quickly add to that. You know, the investment in public health infrastructure has to be federal dollars. And to the extent that we have any hope, it will be that the new administration recognizes that. But what the state can do and has done a little bit better over the past few years is allow for greater flexibility at the local level. For many of you who've ever worked in government or in a government public health department, you know that you have these stovepipes of funding, these really rigid silos that are hard to break through. And so while your overall budget may look reasonably healthy, your flexibility, your ability to use money across programs is almost nil. And that is sort of really inexcusable in this day and age when we recognize the determinants of many of these various different diseases are the same. So that's one thing the state can do and has done a better job of going forward. The other thing I would say that I'm hopeful about is this whole idea of creating kind of a virtuous cycle. Finding ways to use savings, healthcare savings, to invest in prevention. And then allowing tracking essentially those investments through the entire cycle to show that they're actually paying dividends at the end of the line. And, we have a whole bunch of problems with that, the wrong pocket problem and, long-term, short-term issues. But we can do this with something like a soda tax or, establish a wellness trust and, take those savings and reinvest them in the same interventions, the same prevention strategies that delivered the savings and create this sort of virtuosity in this state. I think to the extent that this can be done anywhere, it can be done in California because we have the best understanding of the benefits of prevention, although primarily now we're still in the rhetorical phase. We're not in the policy experimentation phase. And we need to move into the policy experimentation phase to show that we can start delivering these savings and capturing them. The healthcare delivery system needs to lean into community. And that's sort of been my mantra, that, we're not asking, the health system to start doing prevention. We're asking them to start leaning into it, to start supporting those efforts in their communities that have the potential or have been shown through pilots and trials to actually reduce downstream healthcare expenditures.
Thank you. Yeah, I really appreciate both your answers to those important questions. I think we probably have time for one more question. And unfortunately, we're getting close to our hour and a half. But Renee, so can you remind me who's next? Yeah. I think maybe for the final question, and then also maybe how we're gonna, if we have additional questions, comments, how we might be able to share those with both Tony and Sandra for potential follow-up as well. I think that would be important.
Sure. So Mimi, if you want to unmute and ask your question, and if people have other questions they want to put in the chat, we can capture those. Thank you.
Hi, Mimi Doohan, cohort 18. And I was in Sacramento at our seminar as a new health officer of Mendocino County, rural county, when we did our politics retreat, if you will, and have learned so much being a health officer through the pandemic. Thankfully, as of September 1st, I'm a deputy health officer. But one of the things that I've found to be a real gap that we need an urgent solution to is the gap between public health, and I'm going to speak from my rural community, and the clinic systems when we need to have testing done in much more expansive ways, for example, with schools opening. So we have schools opening, we have children going back to school, and we have no clarity about who should do the testing. And in Mendocino County, there is no healthcare delivery system in the public health department. And we need to build more bridges between public health and our FQHCs, for example, right now. So are there any innovations that you see coming, or any kind of rapid cycle innovations about how we build those bridges, for example, around testing with COVID?
Yeah, Mimi, first of all, let me just say, I heard your chip yesterday, and I was just incredibly moved by it. So congratulations on the work that you've done, really extraordinary. So I'm glad I had the chance to say that to you directly as opposed to the chat. So thank you for that. And thank you for serving as a health officer, because those jobs are enormously stressful right now. I would say this, look, I think that the FQHCs really, from a delivery system point of view, are about as close to the ground as you can get. And they've been there through thick and thin, through fires, through all kinds of situations. What hasn't happened is really seeing them as a systematic part of our testing infrastructure. A little bit of that, you can do a little bit of hindsight. A little bit of that was, let's see if we can rapidly stand up testing all across the state without actually sort of thinking about who the delivery system arm is. And by the way, I see testing, contact tracing, isolation, and quarantine as one entire system. And when we go back and write, what did we learn? One of the things we will learn, I think, from this pandemic is because testing was such a problem at the outset, we focused on it and didn't think about the throughput. And as you know, as a public health official, Tony knows, and others, you actually have to think about the entire system through. You can't just build them piece by piece, which, again, we were all on a pivot, so that'll all be hindsight. But I think it's an important message because who provides the support to the family that Tony described, right? That doesn't speak Spanish, and if he doesn't go to work, there's no food on the table. And so I do see the FQHC clinics as a key part of the interface between public health and the delivery system, and particularly in places where there isn't a mature delivery system. And the other thing is, I think the University of California is recognizing that as a public institution with all of its assets and resources, has a responsibility to reach out into community at this moment, Mimi. So one of the things I would concretely recommend is thinking about reaching out to a partner, someone who's doing work in rural areas, Latinx community. There's a Latinx Center of Excellence at UCSF, and really try to build some infrastructure capability around the FQHCs and the community itself to be able to do not only the testing, but what Tony also mentioned, which is to lay the groundwork for vaccinations. You know, one of the things we are all in is a history and time which I could have never imagined to be the case, where you have people that are just non-science believers, right? Not just anti-vaxxers, just don't believe in science at all. You got this QAnon, and you got all these, and so our voice and credibility really rests in people who work in community and deliver services there. And those are the FQHCs in this state in particular. So I would see that as a hub. And again, I wouldn't just look at testing, I'd look at it all the way through. Testing, contact tracing, isolation if you need to support them to do that, and quarantine for families in those communities. Again, thanks for your chip, Mimi. I was quite moved by it.
Thank you.
Yeah, I don't have really anything to add to that. I think that's exactly right. I would say that there has been some innovation in the testing space. And, you know, there's a Yale test, a PCR test now that's saliva-based. That's actually, you know, for schools, it's a lot better than shoving a Q-tip up a kid's nose. And, you know, there's a great webinar actually that UCSF put on a couple weeks ago. So it's Bob Wachter, and there's this Harvard public health scientist by the name of Michael Minna, who talks about, you know, essentially low sensitivity testing strategies for public health purposes. And, you know, he makes the argument that we don't actually need a high sensitivity test to open up a school. High sensitivity tests actually are actually too sensitive. They pick up a lot of non-infectious virus. And the goal is actually to have a relatively lower sensitivity test that you use frequently. In other words, testing either daily or up to every 3 days with a quick turnaround on results can actually blunt an epidemic more effectively than using sensitivity tests can do. So check out that webinar. It's again, UCSF has a weekly or bi-weekly webinar, and there is one recently with Dr. Michael Minna from Harvard. He also, you can find a paper that he's written on this. And there are some strategies for testing that I think will allow for institutionalized settings to feel much more comfortable about opening up and having a mechanism for ensuring that people are safe.
Thank you.
Great. Thank you for the question, Mimi. And I know we've gotten a lot of comments in the chat about some experiences and even some best practices that are starting to emerge in different counties. So definitely take note of that. Unfortunately, we are at time. As you can imagine, this conversation could have gone on for quite some time, especially given the fact that we just had the privilege of having both Tony and Sandra join us as true inspirational leaders who are committed to public health and the health and well-being of vulnerable populations. And sincerely want to thank you on behalf of all of us for taking your time and bringing honest conversation to today. It really means a lot, and I think we've taken a lot that we're gonna take back to our own work and lives and really reflect on as we go forward. So thank you so much. And And with that, I think I'm ready to pause first of all, and then hand it over to Maria, who's going to now transition to our next step, which is, I think, graduation. Correct, Maria?
That's correct. Thank you so much. And thank you for this wonderful, wonderful panel. And yes, graduation, so I won't hold you guys too long, but I do want to make sure that I do 3 things before we break off and celebrate you, Cohort 18. One is, I just want to tell you that my heart is very full. It is so full to see each of you here and engaged and present. I do want to thank you all for doing that. I want to thank our fabulous speakers and our moderators, the staff behind the scenes that has done so much work to make sure that this was just absolutely perfect. So thank you.
Nicely done.
Absolutely. I want to thank the planning committee, Judith Sansone, Kanoe Allen, great job. The board of directors, thank you all for your support, and of course the foundation. Before I transition to your graduation, I do want to say a couple of words. I'd like to have us reflect as this 500 strong plus, I think, cohort of great leaders. There's a couple words, or not a couple, there's quite a few words that describe the last 2 days for me. And I'd like to have you reflect on that. And the words that come to mind are thoughtful, courageous, brave, humble, vulnerability, resilience, powerful, critical, privileged, leadership, reflective, inspiring, precious, a gift, historical, celebratory, timely, inspirational, thought-provoking, healing, and hopeful. So my heart is very full. I can't thank you enough for having shared of yourselves, sharing with us. And with that, I also want us to not forget this conversation, and I'd like to invite us to continue the conversation moving forward. Let us continue to connect on these very important topics. Let's continue to keep each other and ourselves accountable, and let's continue showing up for our patients, our community, ourselves, each other. Thank you again, and a big round of applause to Cohort 18. Welcome to the 500 strong collective of healthcare leaders. And now I hand it over to Renee. So big round of applause, guys. You did it. Renee.
Congratulations to the Cohort 18. Fantastic.
Yeah, so thank you again, Tony and Sandra and Sarita for moderating. We're gonna go into a celebration for Cohort 18, but we're gonna do a toast, and we wanna make sure that everyone has a drink in hand. So please take a couple minutes to go and get your beverage. We'll take a 2-minute break so you can get what you need, and then we're gonna resume with our graduation and celebration.
Thank you guys, nice to be with you.